Okay, great. There you go. I'd next like to introduce Dr. John Valentine. He's going to speak about inflammatory bowel disease. So Dr. Valentine is a professor of medicine at the University of Utah School of Medicine in the Division of Gastroenterology, Hepatology, and Nutrition, and he specializes in ulcerative colitis, Crohn's disease, and celiac disease. Dr. Valentine received his MD degree from the University of Texas Medical School at Houston in 1985. He received his training in internal medicine at the Medical College of Virginia and his training in gastroenterology at the University of Florida. While on faculty at the University of Florida, he was a professor of medicine and served as chief of the gastroenterology section at the VA Medical Center and founded the Southeastern Center for Inflammatory Bowel Disease. He remains active with Crohn's and Colitis Foundation of America and has served as their co-chair in the Patient Education Committee. He is also a member of the editorial board for the Journal of Inflammatory Bowel Disease. He is a fellow in the American Gastroenterological Association and is director of the University of Utah Inflammatory Bowel Disease Center. Thanks.
Well, thank you. I've been in Utah for a little over a year now, and I'm enjoying it quite a bit. I did know about this program last year because I saw a flyer somewhere, and I wished that I had been able to take the number of days off it would have been necessary to come and attend. So unlike hepatitis C, where there's all kind of rules and guidelines on how to treat the patients, that's not true for ulcerative colitis and Crohn's disease. But since this is largely a primary care audience, and IBD touches almost all subspecialties, I'm going to show you that these are indeed systemic diseases. And gastroenterologists in general, I'm not speaking about all of them, aren't very good about treating things outside the gastrointestinal tract. So certainly your patients with inflammatory bowel disease, you can be a great benefit to the patient by watching out for some of the things that we're going to go over today. So for disclosures, I also involved in clinical research, and that's where I received research funding from a variety of companies. I've been a consultant for Genentech. I'm not on anybody's speakers bureau. So inflammatory bowel disease largely consists of ulcerative colitis and Crohn's disease. I throw a lot of other things in there because they're chronic inflammatory like celiac disease and lymphocytic colitis and collagenous colitis, but largely when people say inflammatory bowel disease, they mean ulcerative colitis and Crohn's disease. And there are over 1 million people in the United States. I think it's probably approaching 2, but finding out exactly how many people have this disease, since it's not reportable, is a little bit difficult. About 10 to 20% of patients who have inflammatory bowel disease, it's difficult to tell at the initial diagnosis which disease they have. Fortunately, it often will present itself over time, and we can put it in one category or another, but still sometimes we are not correct, and the disease starts doing things. Usually it's somebody with the diagnosis of ulcerative colitis, then it starts doing things like developing fistulas that only Crohn's would do, and then we change the diagnosis. Inflammatory bowel disease is increasing worldwide, and in your handouts on the CD-ROM, there's slides showing how this progresses over time. But this is largely a disease of North America and Europe, Northern European countries, but other parts of the world like India and China, which are now industrializing, are starting to see inflammatory bowel disease where they didn't see it before. And I don't believe that is all just because of improved diagnosis. So this is true both of ulcerative colitis and of Crohn's disease. And so what it is about westernization, industrialization, which is leading to this, isn't clear. You can make some speculations. I doubt it's only one thing, but most likely it's a combination of things. And we'll go over some of the proposed environmental risk factors. Inflammatory bowel disease has its peak onset between the age of 15 and 25, but it can occur at any age. Certainly, when people get diagnosed in the older age groups, you have to start thinking of other things like diverticulitis, ischemic bowel, radiation injury, if they've had radiation therapy for a cancer, which isn't really applicable to the younger age populations. Some patients are diagnosed as young as 1 or 2 years old. something which I've seen recently as those kids have graduated from the pediatric gastroenterologist, but 15 years ago, in the patients I saw, nobody had been diagnosed that young. So I believe that the epidemiology is changing. In support of that was this study that was done in Wisconsin. Every pediatric gastroenterologist in the state participated, and they followed or got all the information, all their new diagnoses of inflammatory bowel disease. And unlike what you're going to read in the books, in this population, ulcerative colitis was less common than Crohn's disease. And if you look now, this is all pediatrics. Look at the kids down here who are diagnosed at age 2 and 3 years old. The peak age of onset was about 12 and a half in this pediatric group. The other curious thing was that if you read in the textbooks about this as a Caucasian, Jewish predominant disease, and that's not true. All ethnic groups are now getting this at the same rate. So here is the ethnic breakdown of the pediatric population in the state of Wisconsin, and here is the breakdown of the new IBD cases. And you can see here, African American 6% in both groups, Hispanic 4% in both groups. So it largely mirrored the population of the state of Wisconsin. It didn't matter whether you were rural or lived in an urban center, didn't matter whether you're Jewish, non-Jewish, everybody was getting it at the same rate. Now, what causes Crohn's? We don't really know for sure. We know that there's a genetic susceptibility, but the genes in a population don't change as rapidly as inflammatory bowel diseases come on. Now there have been over 100 genes linked to inflammatory bowel disease, and part of the thing that makes it difficult to treat and frustrating for both the patients and the physicians is that every IBD patient has a different mixture of those 100 genes. So who's going to respond to which medication becomes a very frustrating and unfortunately kind of a trial and error approach based on some literature guiding us to what we think should happen, but in an individual patient, which medication are they going to do well on is purely a guess. We also know that there are some environmental factors, and these are starting to be looked at in greater detail. The gut microbial flora, we believe the immune system is reacting against the flora. Many of the genes that have been identified actually deal with the host cell bacterial interactions. Risk of infections or lack of infections, the hygiene hypothesis, which has been linked to the increase in many autoimmune diseases and in asthma. How much that plays a role, hard to say. Personally, I don't believe that lack of intestinal parasites is why people get inflammatory bowel disease. However, parasites can modulate intestinal inflammation, so there could be some groups where this might play a role. So because of the shared genetic background of many autoimmune diseases, some of the genes identified for IBD are specific to inflammatory bowel disease. Others are shared with other autoimmune diseases. So it shouldn't be surprising that patients or their families tend to have clusters of of other autoimmune diseases. Everything from hemolytic anemias, insulin-dependent diabetes, primary biliary cirrhosis, sclerosing cholangitis, thyroid disease, Takayashi's arteritis, celiac disease, psoriasis, all these autoimmune diseases have been linked to various populations. So it doesn't mean that any one patient will have all these, but I have seen patients who've had primary sclerosing cholangitis and ulcerative colitis and celiac disease. So I do look for these other diseases. And if you have patients who have autoimmune diseases in the family, if they're presenting with symptoms that would suggest maybe they have inflammatory bowel disease or irritable bowel syndrome, but taking a closer look is probably worthwhile. What about the environmental triggers? Largely speculative, but antibiotic use can change the gut flora, and we're only now beginning to realize the impact that might have. Show me a 10-year-old in the United States who's never been on antibiotics. It's pretty rare. Diets, low in sugar, low in fiber, high in refined sugars, can alter the gut flora. Non-steroidal use is damaging to the to the barrier function of the intestine. There are some patients on nonsteroidals who will get a colitis. You take them off, it goes away. So that could be a contributor. Stress, the lack of infections that we talked about. Low vitamin D levels are a risk factor for autoimmune diseases, and I check that in everybody. I know vitamin D has been very popular. Some people stating this being checked too often. We know what levels of vitamin D are necessary for optimal bone health. I submit that we don't know what levels of vitamin D are necessary for optimal immune function. So in Florida, where I moved from, 75% of the patients in the IBD clinic had low vitamin D levels, and it's about the same here in Utah. Curiously, smoking is protective against ulcerative colitis. And a lot of times in the older age population, it's a year or two after they quit smoking that ulcerative colitis comes on. And it aggravates Crohn's disease. The disease course is worse. They need more immunosuppressive medications. And if they quit smoking, the disease becomes easier to manage. Now, how do you diagnose inflammatory bowel disease? And sometimes it's obvious. It couldn't be anything else. And other times it's a big hunt to try to figure out whether it's inflammatory bowel disease or not. Fortunately, patients, in my experience, can be very understanding when you say it could be, but I want to be sure before I put you on an immunosuppressive medication. So they're rightfully respectful of what that's going to mean, potential lifelong immunosuppression. So let me just go over what ulcerative colitis and Crohn's disease, how we can differentiate them. Crohn's disease can be anywhere from the mouth all the way to the anus. As you can see here, about half the patients have in their ileocecal region, that's where Crohn's likes to go. About 20% can be only in the small intestine, and about a third can be only in the colon. That can make it difficult to distinguish from ulcerative colitis. And then rare, but I've seen it, it can be in the esophagus, the stomach, extraintestinal manifestations, which can be the presenting manifestations, and I'll go over those in a few minutes. In ulcerative colitis, about 28% have inflammation confined to the rectum. If you notice in all these, the rectum is always involved. So if someone looks like they have ulcerative colitis, but the rectum is normal, the rectum is less involved, but they haven't been on any therapy or not on suppositories, I'm really suspicious that it's Crohn's disease. Given that the inflammation can be confined to the rectum or can go up just to what we call left side disease or can go over the entire colon, this also has implications for which type of therapies we might use. A suppository can treat the rectum, but it's never going to treat a pancolonic disease. So the symptoms of inflammatory bowel disease can be very similar. There are some things that will distinguish them. Both can have increased stool frequency. If you have only proctitis, just the bottom part of the rectum inflamed, it can actually present as constipation. They have enough functional, healthy colon to form a formed stool, but then they get spasm in the rectum, which makes it more difficult to have a bowel movement. Abdominal pain can occur in both, but is more common in Crohn's disease and may be associated with a mass. Blood in the stool is almost universal in ulcerative colitis and is variable in Crohn's disease, and that can be attributed to which parts of the bowel are inflamed. Some historical points that are suggestive of somebody with inflammatory bowel disease or should increase your suspicion. If they have a family member with inflammatory bowel disease, that's the number one known risk factor is having a family member with IBD, although most patients don't have family members. The present blood in stools suggests something inflammatory. The number one cause of bloody diarrhea is obviously infection, so it's important to rule that out. But irritable bowel syndrome should not have blood in the stool. It shouldn't have inflammatory cells in the stool. Systemic and extraintestinal manifestations would also help exclude irritable bowel from inflammatory bowel disease. And perianal disease, perianal abscess, history of fissures or fistulas, even if they're years prior, should also increase the suspicion that this could be inflammatory bowel disease. So sometimes patients after having a GI tract infection can be left with altered bowel habits, and sometimes that's inflammatory bowel disease. Sometimes it's what they call post-infectious irritable bowel syndrome. But if they have inflammatory cells, have some of these extraintestinal manifestations, nocturnal diarrhea, they're asleep and they get woken up having diarrhea. It's not what we typically see with irritable bowel syndrome. And that should prompt a further investigation. Similarly, alternating diarrhea and constipation. Somebody has formed stool, then they'll have a day of loose stools, then the next day they're constipated, back to formed stools. Inflammation doesn't come and go that quickly. So that's unlikely to be inflammatory bowel disease. There are many extraintestinal manifestations of inflammatory bowel disease, which is what I'm trying to point out. This is a systemic disease and may present with a variety of different issues. Eye inflammation, oral ulcerations, back pain and ankylosing spondylitis, increased rates of kidney stones and osteoporosis, sacroiliitis, both arterial and venous thrombosis. Now, why there's an increased rate of arterial thrombosis, I have to tell you, I don't understand that, but has been seen. A variety of skin disorders, peripheral arthritis, growth failure. Half the kids with Crohn's disease will present by falling off their height and weight growth charts before they have any symptoms. So that should be a clue. And then the associated liver disorders. Another risk factor is colon cancer. In ulcerative colitis, the risk of developing dysplasia or frank cancer is 18% after having 30 years of disease. So at the end of this talk, we'll go over what the recommendations are for screening colonoscopies. This is a picture of oral aphthous ulcer. They can be most of them are much smaller than this. Eye inflammation, both episcleritis and frank uveitis. Here you can see pus in there. This is an ophthalmologic emergency even before it gets this badly. I've never seen one this bad. I have seen the other. And these are pictures that I took of my patients. So this is erythema nodosum, pyoderma gangrenosum on the lower extremities. And yes, I got on her for allowing it to get this bad before she came in. The peristomal pyoderma, so here's her ileostomy, and then she has this pyoderma gangrenosum adjacent to her ileostomy. This can be a big complication because the stoma appliances are going right over the top of this, keep traumatizing the area, you don't get a good seal. And then this is cutaneous Crohn's disease, which I've only seen in African Americans, but it can occur in other races too. But my suspicion is there's a higher rate of this in African Americans, and this is in the gluteal cleft. But it can occur anywhere in the body, but the gluteal cleft and inguinal regions is most common. Physical findings, there's not a lot to distinguish them until you get down to things like an abdominal mass. Very unlikely for that to occur in ulcerative colitis. Skin tags, anal fissures, perianal fistulas, rectal vaginal anal stenosis will all be an indication for Crohn's disease. So in order to make the diagnosis, we need the clinical picture, the suspicion, endoscopic and pathologic specimens to confirm your diagnosis, because I want a piece of tissue if at all possible. I get very uncomfortable if I don't have that, although I have to admit when patients have had inflammation that I think is IBD, and it's in parts of the small bowel that we just can't get to, I have gone ahead and treat that, but I don't like doing it. And then it's important to fully evaluate the cause of the diarrhea. I know we'll have a talk after this on C. diff, but I'm going to harp on that a little bit, and hopefully then Dr. Gonzales can expand on that. Blood work, CBC, is the platelet count elevated? Is the white count elevated? SED rate or CRP, not everybody will get a CRP elevated, but if it is elevated, it tells you something inflammatory is going on. Serologic markers can be helpful, but they're not good enough by themselves. And I'll show you a slide here in a minute about why I think that's the case. Fecal calprotectin or lactoferrin, these are proteins that are made by inflammatory cells. They should not be elevated in the stool in irritable bowel. They will be elevated in an infection. They'll also be elevated in inflammatory bowel disease. And I find these very useful in patients who don't have classic symptoms trying to figure out what's going on. So the antibodies that I mentioned, these are antibodies for Crohn's largely against microbial or fungal peptides. This is Saccharomyces cerevisiae or brewer's yeast. And about 60% of Crohn's patients will have an antibody against that. Outer membrane porn C of E. coli is about 50%. CBER is a flagellin protein, bacterial protein, and that's also about 50%. You can see that these are rarely or infrequently elevated in ulcerative colitis. A perinuclear anti-neutrophil cytoplasmic antibody is found in about 65% of ulcerative colitis. And in Crohn's patients who have it, it tends to look more like ulcerative colitis, predominantly in colonic disease. But you can be negative for these markers, or if you're positive for these, it doesn't really tell you which one they have. Now, the reason why I say they're not good enough is that here's the CBER in Crohn's disease compared to UC inflammatory controls, so it can help distinguish that. But the reason why I say it's not good enough is in celiac disease, for example, at diagnosis, 50 to 60% of those patients had an antibody against the ASCA, the Saccharomyces cerevisiae, about the same level as in Crohn's disease. In intestinal tuberculosis, it's also about the same level. And at the University of Florida, we had a collection of kids who had glycogen storage disease. And glycogen storage disease type 1B gets a gut inflammation. And they were also positive for the Crohn's markers. So there's other things that can give you positive markers. So it can point you in the direction, but I don't think it's good enough by itself to make the diagnosis. C. diff is a very important problem, especially in inflammatory bowel disease patients. I get these all the time. Patient isn't doing well, I'm thinking about changing therapy, I get a C. diff first to make sure that that's not getting in the way. And I found one recently, a young man who was in a clinical trial, wasn't getting better. He was C. diff negative at the start of the trial. I got a C. diff on him and he's positive. So these are a major problem. And in this study by Ashwin, I can't pronounce his last name, looking in these cohorts of IBD versus non-IBD C. diff infection patients, the patients with inflammatory bowel disease had twice the mortality, 6 times more likely to go to surgery, 3 times longer length of stay, and twice as likely to require a blood transfusion. So those are really some significant morbidities and mortality. This was presented at the GI meetings last year. This was out of a single center, and they looked at their patients with inflammatory bowel disease from 2005 through 2010 who were admitted with C. diff and compared that to patients and looked at their treatment. They had 67 ulcerative colitis patients and 58 Crohn's patients. And the patients who were treated with metronidazole did significantly worse. 12-week readmission rate, 35% if they were treated with metronidazole, 2% if they were treated with vancomycin. 30-day readmit, similar trends. Colectomy was about the same. Death rate was about the same. So I'm told that the upcoming American College of Gastroenterology guidelines are going to recommend vancomycin as the first-line therapy for patients with inflammatory bowel disease that have C. diff infection, regardless of the severity of the C. diff infection. So what are the indications for endoscopy? One is you need to obtain an accurate diagnosis, assess disease activity, possible extension of the disease, dilate strictures in those patients with Crohn's disease who have strictures, and for colon cancer early diagnosis in long-standing colonic disease. And this is what a normal colon would look like. So kind of flesh tone, you can see the blood vessels. And with mild inflammation, you get the loss of vascularity. That's because of edema in the bowel wall. And as it gets worse, you get friability and erosion, some mucopurulent exudate. And then with more severe disease, you got frank bleeding with ulceration. In Crohn's disease, it can be patchy. You can get some superficial ulcerations. This can progress to these kind of irregular ulcerations. Here you see more erythema and edema of the surrounding wall. You can also get what they call bear claw ulcers. So here you see these longitudinal ulcers, and you can see the depth right there. I guess similar like if a bear just dragged its claw down the side of the wall. And I've only seen this twice. All this kind of pale yellow, there's no mucosa left. It's gone. What you're looking at here is submucosa. And both cases I've seen of this is Crohn's disease, even though we couldn't tell it at the initial time. In this particular gentleman's case, went for a colectomy. Later, because of some other nonspecific symptoms, I put a scope in his ileostomy, and he had ulcers in his ileum. So at the time that he had his colectomy, he didn't have ulceration in his ileum. All the inflammation was confined to the colon. So what are the treatment principles for inflammatory bowel disease? Well, determine the underlying location, cause, whether it's ulcerative colitis or Crohn's. Many of the treatments are similar, but this creates a huge difference if surgery is necessary. Tailor the therapy to the patient's manifestations, achieve and maintain remission. You don't want to let people keep flaring and we'll just treat the flares when they occur. Then monitor for toxicity and complications. So first line therapy for inflammatory bowel disease, mostly for ulcerative colitis or very mild colonic Crohn's disease, or the mesalamine therapies, and there are many different formulations of this. You have enema therapies, suppositories. These are preferred therapy for proctitis. Nobody wants to do these long term, but you're putting high doses of the medication right where they need it, and then you can transition them over to oral therapy when they respond, or add the oral therapy at the same time, take the suppository enema therapy away once they're doing better, and maintain them on the oral therapy. There's multiple different formulations of oral therapies of the mesalamine, but they're all designed to deliver the mesalamine to the colon. And very little of this is delivered to the small intestine, where usually mesalamine is rapidly absorbed, but it's very poorly absorbed from the colon. So for rectal sigmoid disease, suppositories can be beneficial, and enema will get up to the splenic flexure, and then you need oral therapy for pancolitis. For the second line treatments, or first line for Crohn's disease, is budesonide. Entocort is a formulation of budesonide which is delivered to the terminal ileum and proximal the cecum and ascending colon. It doesn't do a good job of delivery to the rectum because it's readily absorbed. This is a very potent steroid, which then has a high rate of first pass metabolism. All the blood flow from this part of the bowel goes through the liver before it goes to the rest of the body. And budesonide is 85 to 90% inactivated first time through the liver. So you can get the benefits of steroids with a lot less of the side effects that you typically see with oral prednisone. Prednisone therapy, typically we use 40 to 60 milligrams daily until response. Within the last 2 months, maybe 3 months, a form of budesonide has a colonic delivery mechanism has been released called Uceris. Like all new things, it is not inexpensive. For the patient, though, with distal colonic disease that needs steroids but is diabetic or gets severe depression on steroids, this can be a good option. And whenever you start steroids, you need to be considering a steroid-sparing therapy because chronic steroids, one, don't maintain remission, and two, are loaded with side effects. And I don't need to mention in this audience what all the side effects are, but hypertension, risk of infection, diabetes, osteoporosis, osteonecrosis, cataracts, myopathy, psychosis. Had one patient tell me they got homicidal on steroids. I was not going to treat them with steroids. So they are something that they're inexpensive, at least prednisone is. They can work quickly, but they're not a good long-term therapy. So how do we manage the risk of steroids? Crohn's disease, just because of the chronic inflammation, has an increased risk of osteoporosis, and steroids can aggravate that. The AGA's one of the commentaries on the AGA guidelines about bone density testing in patients with GI diseases is that we need to be more specific to identify the patients who are at higher risk. I disagree, because you want to catch the patients before they have osteoporosis, not once they have it. So consider getting bone density testing early in Crohn's patients. Once you have that, if they're not on chronic steroids, you don't need to continue it. Calcium and vitamin D supplements while taking steroids. Check vitamin D levels. A low bone density won't distinguish between osteoporosis and osteomalacia. And if they are on chronic steroids, then recommend a repeated bone density test every 1 to 2 years to make sure you're not rapidly losing bone. If patients are on chronic steroids or aren't responsive, we need to move to second-line therapies, azathioprine, 6-mercaptopurine, and methotrexate. They're commonly used as what they call steroid-sparing agents. They can take 2 to 3 months to become effective, so when somebody's really ill, that's not the drug that's going to get them better. You do need to monitor for routine testing for safety. Leukopenia, abnormal liver tests are quite common, especially at the higher doses. Thiopurine methyltransferase is the enzyme which breaks down azathioprine and 6-MP. 1 in 300 people don't make that enzyme, and they will get severely neutropenic quickly. Now, just because a patient has a normal enzyme activity, though, they still can get neutropenic on azathioprine and 6-MP. So while they're unlikely to get severely neutropenic on you in the first couple weeks, you still have to monitor, and it's recommended somebody on a stable dose of azathioprine to get a CBC and LFTs every 3 months. What are the adverse events to azathioprine and 6-MP? Allergic reactions is about 2%, nausea 2%, abnormal liver test is about 2%. Pancreatitis, I don't think it's as high. Other literature says less than 1% serious infections. And there is an increased risk of lymphoma. So it's about doubles if you're on azathioprine and 6-MP. There's also an increased risk of skin cancers. I'll touch on that in a few minutes. The anti-TNF therapies, these have been a transformation to how we treat patients with inflammatory bowel disease. They work rapidly. They're outrageously expensive. So infliximab, for example, an infusion which is given every 2 months can be between $5,000 and $10,000 per infusion. But for patients who have severe ongoing inflammation because of the risk of surgery, becoming TPN dependent, these medications can be very effective. There's 3 forms that are approved for marketing for inflammatory bowel disease: infliximab, adalimumab, and certolizumab. There are a couple others that are approved for rheumatoid arthritis, one of which, golimumab, is in front of the FDA. When you're preparing someone to go on anti-TNF therapy, you need to get a TB skin test. Anti-TNF therapy is very good at letting latent TB run wild. And I don't always get chest x-rays, but if somebody's had TB and they've been treated, or they're on steroids, so you don't know if you can trust their TB test, then a chest x-ray is recommended. You also need to screen for hepatitis B. Anti-TNF therapy can allow reactivation of hepatitis B. In hepatitis C, the anti-TNF therapies don't seem to do anything to the virus. The viral levels stay the same, the disease doesn't progress, but still want to know if somebody has hepatitis C also. Now, some patients don't respond to anti-TNF at all. They're called primary non-responders. And then there's the patients who do great on them, and then after a while start having symptoms. Those are called secondary non-responders. And actually, it should be loss of response, not a non-responder. But if somebody is a secondary failure, the first thing you need to do is exclude infection. C. diff, salmonella, shigella, all the other stuff that causes those kind of symptoms. Once that's excluded, if there's no inflammation present, we need to look at other things that might be causing similar types of symptoms. Have they developed overt celiac disease? Do they have irritable bowel? Do they have small bowel bacterial overgrowth? And then if inflammation is present, we can measure drug levels and antibodies to infliximab. The new test for adalimumab is coming out. Certolizumab doesn't have one yet, but it shouldn't be too far away. If their drug levels are high, then they're breaking through the anti-TNF mechanism, and it's recommended to change therapy. If their drug levels are zero and they have high levels of antibody, their immune system now is recognizing the sporin protein and starting to clear it out. Giving more of the same medication isn't going to overcome that, and that's an indication to switch therapy. There's only been one head-to-head trial in Crohn's disease of azathioprine versus infliximab or any of the anti-TNF agents. And if you look at the 26-week point off of steroids, azathioprine did surprisingly poorly. Now, I'm not a believer that one trial means everything else we did before isn't correct. I think this was falsely low for some reason, but in this trial, only 30% of the patients were in remission on azathioprine, 44% of the patients were in remission on infliximab, but the combination of the two, 57% of the patients were in remission off steroids 26 weeks after initiating therapy. So some people now have said that we need to use combination therapy because of this increased improvement. There will be a price to pay. I agree with people with very severe disease, we should go to combination therapy. People with milder disease, I think we're going to be over-treating a lot of patients if we put everybody on combination therapy. Also of interest to me is why is there improvement? Is there additive effects of these two drugs, or is the azathioprine just preventing antibody formation against this antibody-based therapy? And if that's the reason, are there ways for us to do that better? And I think we will identify ways to preventing the antibody formation. Now, there are some reasons for improved remission rates, improved mucosal healing, reduced antigenicity, reduced steroid requirements, but increased lysocyl lymphoma, increased cost, compliance with adding additional or additive medications. So the adverse reactions or events with anti-TNF therapy, injection site or infusion reactions, and these can be severe. Drug-related lupus-like reactions, I think is a whole lot less common than this. All joint pains after anti-TNF therapy doesn't mean it's a lupus-like reaction. You can get antibody complexes with the drug that can cause something similar. Some strange skin rashes that look like psoriasis but aren't can occur. Tuberculosis is about a 5 in 10,000 rate, and I've had one of those. Increased rate of non-Hodgkin's lymphoma. And then there's case reports of strange neurologic events, developing of multiple sclerosis, aggravation of congestive heart failure. So it's a relative contraindication in patients with class 3 heart failure to use anti-TNF agents. So what preventive measures do we need to take into consideration? There's increased rates of skin cancer, both melanoma and non-melanoma skin cancer, so minimize sun exposure, wear sunscreens, we can replace the vitamin D that they're missing. Annual pap smears for women, patients with immunosuppressive drugs who have HPV, that can be more difficult to control. And then if you're on triple therapy, you need to consider the trimethoprim sulfa or dapsone for those allergic for PCP prophylaxis. Immunizations is also where we can help prevent problems with patients with inflammatory bowel disease. Obviously, live viruses are contraindicated in patients on immunosuppressive drugs, so we want to immunize before they're on steroids, azathioprine, or anti-TNF. Avoid the live vaccines. So what's the definition of being immunosuppressed? Treatment of 20 milligrams of prednisone for greater than 2 weeks or with 3 months of stopping, azathioprine, 6-MP, methotrexate, anti-TNFs, and within 3 months of stopping if you're significantly malnourished. This is from the 2013 CDC, and if on immunomodulator drugs, immunosuppressive, contraindicated, or the zoster, varicella, MMR, live viruses, other non-live virus vaccines are fine. Real patient, not her picture, 32-year-old, pan-ulcerative colitis for 13 years, treated with mesalamines only. She's only had 4 short courses of flares that were treated with steroids. And she was referred to the IBD clinic because on her colonoscopy, she had a sigmoid mass with low-grade dysplasia. Our pathologist reviewed it and said, it's indeterminate, there's too much inflammation. So we suppressed the inflammation and rescoped her. And here's her mass. And it was read as at least high-grade dysplasia arising in the background of inflammation. And here it is on CT scan, you can see this thickening of the bowel wall. And on surgery, this was a well-differentiated mucinous adenocarcinoma. So this is why these patients, they're young. The youngest age I've seen of colon cancer is 18 years old in a patient with PSC and ulcerative colitis. So this is why they need to be in the screening programs. Do they work? Can they help? There'll never be a controlled trial, but in this study, for patients who had never had a screening colonoscopy and developed cancer, they were given a score of 1. And if you'd had 1 colonoscopy, it dropped it to less than half, and if you had 2, it was less than 20%. So we're catching these at earlier ages. They might get a colectomy anyway, but it's still better than having a frank malignancy. So how many biopsies are enough? Well, we're sampling less than 1% of the mucosa when we do the random biopsies, but it's recommended that we need to do a minimum of 32 to 40 biopsies randomly throughout the colon in order to identify dysplasia. How often do you do it? Depends on lots of other factors. And I'll skip this. I didn't go over that. So the factors are how long they've had the disease. More than 10 years of pancolitis, they should get a colonoscopy every 2 to 3 years. Once they've had it for 20 years, it'd be annually. Patients with primary sclerosing cholangitis and ulcerative colitis or chronic Crohn's disease, the risk is so high, it's recommended annual colonoscopies at diagnosis. So what kind of things can we do about medication adherence? You heard Dr. Box say the fewer medicines, the more likely patients are to be able to take their medications. Avoid multiple medications, higher frequency of dosing. Young single men seem to be the worst about taking their medications. So counseling them on the importance of the medication, trying to make the regimens easy, it certainly will improve their adherence. In this study by Susie Kane, this is an ulcerative colitis. Patients were considered adherent if they took 80% of the doses as prescribed, and not adherent if they took less than that. This is the percentage of patients maintaining remission over a 3-year time point. You can see here if they took the medications, 89% stayed in remission, where if they're not adherent, it was down to 39%. Increased inflammation increases colon cancer risk, increases steroid exposures, increases numbers of colonoscopies and hospitalizations. So these are all things to try to avoid. What about medications in pregnancy? The mesalamines are class B. 6-MP and azathioprine class D, but they're commonly used, and we believe that the benefits outweigh the risk. Anti-TNFs are class B. Methotrexate is an X, so it causes birth defects and cannot be used during pregnancy. This study just came out earlier this year looking at anti-TNF medications in pregnancy and placental transfer. So these are monoclonal antibodies. Infliximab and adalimumab are a IgG1, and they do cross the placenta. And Certolizumab is the antigen binding fragment, the FAB fragment, which is pegylated. It increases circulation. And because it lacks an FC receptor, it's not transported across the placenta. So if you looked at the cord blood to maternal ratio of the infliximab, the baby had 160% of the level of the mother. Adalimumab is 153%, and certolizumab is 3.9%. So for women who are very concerned about immunosuppressive drugs and in upcoming pregnancy, certolizumab, if they need an anti-TNF agent, certainly should be reassuring to them. If somebody is already on one of the other anti-TNFs, I don't change them because I think they have a good track record of safety up front. We just want to be sure they don't get a dose right before they deliver. So we would alter the dosing as you're getting into that third trimester. So in summary, understanding the diagnosis is important for effective management. Beware of disease mimickers. Rule out infection, including C. diff. Steroids are effective, but short-term use should be emphasized. And adjust your mesalamine therapies to where the disease location of the colitis. We need colonoscopy surveillance in patients with inflammatory bowel disease, 8 years of diagnosis, and annually in patients with IBD and PSC. Appropriate vaccinations and patient education is appropriate, so the Crohn's and Colitis Foundation of America is a very reliable source of information. And then try to minimize the complexity of the dosing regimens in order to increase the patient adherence. So thank you for your attention, and be happy to take questions.
I'm aware of some patients, I have a few patients that have allergy to bee venom or wasp venom, and you know, the standard of care is, of course, to institute immunotherapy for that, except that they're also on, you know, Humira for Crohn's disease. Do you have anything to say about immunomodulation on people on the, like Humira, infliximab, whatever?
So are you, when you name immunomodulation, you mean?
I'm going to refer them to an allergist, of course. I'm just curious as to what.
Right, for desensitization. I have no personal experience about whether these medications interfere with that. I can always learn from everybody. If somebody knows, please speak up.
I have no idea.
I don't know. I don't think it would hurt, but yeah, I don't have a good answer for that one.
I have one other question too. Is there any ongoing research that you're aware of in the developing world about the rates of Crohn's colitis and ulcerative colitis, or rates of IBD in general in people infected with parasites? I know you said you didn't believe that, but I'm curious. There's got to be some reason that it's getting worse.
Well, what I said was I didn't believe that the reason why we have so much more IBD now than what we used to was because of lack of parasites. There are clinical trials going on right now with parasite therapy to try to induce whatever immunosuppressive effect the parasites have. But you know, one of the things that I've been thinking about now that I'm living in Utah is whether the LDS missionary population would be one that we can look at depending on where patients go, whether they get infected with parasites, and what's their course of developing autoimmune diseases in the future. So I don't have that study planned out yet, but I've been thinking about how we might do that. Okay, Carolyn? Oh, only if they're on triple therapy. And yes. Well, the new test is also outrageously expensive. So it went from about a $400 test to a $2,500 test. Mostly because they say, well, if you don't do this, you're going to give a higher dose of the drug, so the cost of this is still cost effective. I haven't been ordering them. I haven't used it yet, but AROP is also coming out with their own assay. I can't tell you what it'll cost, but hopefully it'll be significantly less than the other one that we're talking about. Okay, thank you.